Everyone, thank you for coming. Welcome to NAUTO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Well, thank you, Erica. I am excited to be with you for this session. Today's session is going to be evidence-based perspectives on behavioral health. Our moderator is KeriAnn LaSpina. Marian Wrobel from Mathematica organized it. And today's sponsor for this session is Journal My Health. So let's go ahead and hear a message from Journal My Health about why they sponsored this session.
Tracy Wilson-Rossman from Journal My Health. We're proud to sponsor NATO today to talk about how patient-generated health data can make a difference for healthcare organizations and healthcare companies. If you're interested in learning how our turnkey solution can help your organization, please contact us at journalmyhealth.com.
Thank you, Tracy. It's now my pleasure to introduce to you today's moderator. So KeriAnn LaSpina, let's go ahead and bring you on stage with me. And I think we're ready to go. So go ahead and take it away, KeriAnn.
Great. Thank you, Norm. I'm KeriAnn LaSpina from Mathematica, and it is my pleasure to moderate today's session on evidence-based perspectives on behavioral health care. Our first presentation is from Nicole Kuzmich, who is a healthcare data analyst at the Center for Improving Healthcare, or CIVIC. And as a reminder, full bios for each presenter are available in the links below the video panel. So take it away, Nicole.
Hi, everyone. Thanks so much for joining. My name is Nicole Kuzmich, and I'm a healthcare data analyst for the Center for Improving Value in Healthcare, better known as CIVIC, based in Denver, Colorado. Today, I'll be presenting ED use for mental health and self-harm, what claims data is telling us about mental health care. First and foremost, I want to tell you a little bit about CIVIC and what we do. CIVIC is a nonprofit, nonpartisan, objective organization. As the designated administrator of the Colorado All-Payer Claims Database, or APCD, CIVIC oversees the collection of healthcare claims from Colorado's public and private healthcare insurers and uses that information to promote price transparency, inform policy, advance health equity, conduct research, and much more. Here's a brief overview of what's included in the Colorado APCD. Medical, pharmacy, and dental claims data from 2013 to 2022, totaling more than 1 billion claims, 40 commercial payers plus Medicare and Medicaid. Overall, we estimate that our database covers more than 70% of the covered lives in Colorado for medical claims. That's quite a bit of claims data that can be put to good use. Now that you've gotten more acquainted with CIVIC and who we are, I want to shift the topic to something that we can all agree is important: mental health. Mental illness can affect people of all ages. According to 2 reports published by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and JAMA Pediatrics, respectively, 1 in 5 U.S. adults experience mental illness each year, and 1 in 6 U.S. youth aged 6 to 17 experience a mental health disorder each year. Those are some pretty severe statistics. What's worse is that many Americans living with mental illness don't always have access to comprehensive services or seek timely care to support their needs. In Colorado, efforts are being made to improve diagnosis and treatment of mental health conditions, reduce stigma related to seeking care, and expand coverage and access to services for those living with mental illness. Despite all of these efforts across the state and country, EDs, or emergency departments, remain a source of support for many suffering from potentially preventable mental health crises. Part of our mission at CIVIC is to support state legislators in their efforts to shape policy with timely data. This request came in from a state legislator wanting data on how the ED was being used to treat folks experiencing a mental health crisis. The data I'll be presenting today provides a snapshot of utilization, cost, and trends for visits to the ED with mental health or intentional self-harm as a primary diagnosis. In order to begin my analysis, I formulated a methodological plan. First, I scoped the project requirements to determine what filters or customizations needed to be utilized in order to narrow down the vast amount of Colorado APCD data to get my numerator. I landed on these key elements. The claim service dates that were included in this analysis range from January 1st, 2016 until December 31st, 2021. Both inpatient and outpatient facility claims with an emergency room flag indicator were included. Of those, only claims with a primary diagnosis of mental health or intentional self-harm were incorporated. Commercial, Medicaid, Medicare fee-for-service, and Medicare Advantage payer claims were included in this analysis as well. Lastly, I needed to determine my denominators for visualizing both percentage of total ED visits and rate per 100,000 calculations. Thus, the total number of ED visits between the years of 2016 and 2021 was used as the denominator for percentages, while the total number of covered Coloradans between the years of 2016 and 2021 was used as the denominator for rates. Claims excluded from this analysis were those with a total allowed amount less than $0, claims with reversals, capitated encounters, secondary payers, and professional claims. Total allowed amount represents the sum of the member liability, for example, copays, coinsurance, or deductible payments, plus the plan paid amount. Also, a couple of data limitations to keep in mind throughout. First and foremost, a quick reminder that this analysis only includes claims with a primary diagnosis of mental health or intentional self-harm. Secondary diagnoses were not included. Visit volume is calculated for distinct facility claims. Generally, there is only one facility claim per visit. However, it is possible that more than one facility claim occurred for a unique mental health visit on the same day. Although we won't review all of these in this presentation, the fields we reported on were volume, median cost, and total cost, percent of total ED visits, rate per 100,000 covered lives, top diagnoses for mental health and intentional self-harm, number of visits that resulted in hospital admission, and demographics-wise, we reported on race and ethnicity, sex, and age. Now, on to the actual data. Let's talk about some of my key findings from this analysis. First and foremost, let's take a look at the baseline data from 2016 to 2021. As you can see, the total number of ED visits with mental health or intentional self-harm as the primary diagnosis code continues to steadily rise year after year, while admissions rates generally stay the same, with a very slight downward trend. In 2021 alone, there were over 25,000 visits related to mental health and intentional self-harm, the highest amount of visits from 2016 to 2021, yet admissions rates are the lowest. Based on current trends, ED clinicians will continue to see increasing numbers of patients for mental health and intentional self-harm. According to an article published by Team Health, instead of providing expectant care while patients board in the ED, it's time for hospitals to take a more active approach to caring for these patients, moving with urgency to secure an evaluation, providing meaningful treatment and reevaluation with the goal of helping patients get better faster. This shift in thinking can help EDs deliver better care, improve the patient experience, and improve patient flow. Admissions data for mental health and intentional self-harm was also a topic of interest for this project. As you can see, in 2021, 8% of all mental health and self-harm ED visits resulted in a hospital admission. Cost data can be seen to the right, with approximately 46 million healthcare payments made for mental health and self-harm related ED visits, and about 20 million healthcare payments made for those same visits that resulted in a hospital admission. Now, just to clarify, healthcare payments means the sum of the member liability plus the plan paid amount. Member liability includes copays, coinsurance, or deductible payments. Now, let's take a look at the top or most utilized mental health diagnosis codes. Anxiety disorder, panic disorder, and major depressive disorder comprised 44% of all mental health-related diagnoses in 2021. According to a study done by Academic Emergency Medicine, anxiety and depression are growing concerns that are often difficult to treat and frequently exacerbated by perceived barriers to care. For example, lack of coverage, cost, difficulty scheduling appointments. These barriers can lead depressed and/or anxious individuals to utilize the emergency department for non-emergent concerns. Currently, most ED providers do not screen for mental health unless it is the chief complaint due to competing care priorities and limited resources. Another concerning finding was that there was a 158% uptick in youth ED utilization for mental health and intentional self-harm from 2016 to 2021. Not only that, but 20% of all mental health and intentional self-harm ED visits were youth in 2021. Like the youth population, Medicaid patients are also increasingly seeking out care for mental illness in the ED year after year. This chart, based on payer type, shows a 196% increase in Medicaid ED utilization for mental health and intentional self-harm from 2016 to 2021. That wraps up the most significant findings from this analysis. Overall, it's clear that this project had an impact, especially since it garnered a lot of public interest, including special coverage by local NBC affiliate 9 News here in Denver. Although this project was a success, there were still some challenges and subsequently lessons learned. Some of the challenges I faced were that the first iteration of this report did not include intentional self-harm diagnosis codes, so I had to use a combination of historical Colorado APCD data and reports and analyses in the wild to help me understand what results made sense. Additionally, due to data improvements being retroactively applied to historical Colorado APCD data, sometimes results differed from the first iteration of this report. This caused a need for collaboration with the data quality team, who was able to verify the accuracy of the data variances. And conversely, some of the lessons I learned were that defining a methodology, creating and gathering context for the analysis before even touching the data is of utmost importance. Having a structured plan makes pulling and analyzing the data that much more streamlined. I also learned that versatility is key. The willingness to change any aspect of a project multiple times so that it creates the most efficient use case possible is absolutely necessary. The data has to convey a message. A quick glance at my bibliography. And that's all, folks. If you have questions or feedback, please feel free to reach out to me at nkuzmich@civic.org. You can also stay connected with Civic on Facebook, LinkedIn, and Twitter, or by joining our email list at www.civic.org. Thanks so much for your time and interest, and I hope to hear from you soon.
Great, thank you very much, Nicole. We have about 5 minutes for Q&A from the audience. If you have questions for Nicole, please put them in the Q&A portion of the chat. And while we're waiting, Nicole, I did have a couple of questions for you. I wondered if the inpatient admissions you were looking at included psychiatric hospitals, and if you had a chance to see kind of how that distribution looked compared to acute care hospitals.
It did not include psychiatric hospitals, but honestly, that is a great addition for the next iteration of this report if it's a possibility. So thank you for asking.
Sure. I also had a question. You mentioned race and ethnicity data. Can you just talk about how that looks in your APCD? Is it well populated? Have you been able to do some validation on that?
Yeah, absolutely. So I did not develop the algorithm. One of my fellow analysts here at Civic did. Obviously, I did use it for this project. It is pretty reliant on the validity of data collection, obviously. Race and ethnicity tends to be something that is overlooked when it comes to claims data. It's not seen as something that's super important. I think its relevance and significance is definitely stepping into the limelight as we are becoming more focused on socioeconomic indicators. But otherwise, it is kind of a hit or miss field. There are a lot of null values, but as far as the data that we've got, we aggregate it as much as we possibly can to get the validity of the actual data as much as possible.
Thank you. And it looks like Betty Harney had a question about whether admissions were to acute or psychiatric hospitals. I think your answer earlier was acute care hospitals, correct?
Mm-hmm.
Great, thank you. Okay, I have one more question for you. I might ask the same question of the other presenters in this session, but I was wondering about your value set for ICD ICD. Did you use ICD-10 diagnoses?
Correct.
Diagnosis
Yes.
codes to identify self-harm? And were you able to like use a value set that's out there that other people can replicate, or was it like a home-built set of codes? How did you come up with that code set?
So we actually utilized one of the measures, and I can bring it up if you just give me one moment. I believe it's ED use follow-up for mental health. It is one of the, I apologize, the term
HEDIS
is
measure.
escaping, the HEDIS measures. I apologize. The term was escaping my brain at the moment. But yes, it is one of the HEDIS measures. It is all of the diagnosis codes that are used in that specific measure. And they do include the entirety of self-harm diagnoses codes, as well as those mental health indicators as well. So that was basically our ICD-10 knowledge base that we utilized.
Gotcha. Thank you. And it looks like we have a question from Marian, who says the increase in Medicaid visits was startling. Do you have a sense of how much is due to a higher Medicaid caseload due to the pandemic versus other factors?
It is hard to say. I will say some of the numbers that I looked at, the utilization numbers that I looked at for this project, didn't give me a significant impact as far as COVID was concerned. Utilization did drop very, very insignificantly in 2020. But by 2021, we got back to kind of a normalized number. So it is difficult to pinpoint the exact reason, but that is a great question. So I appreciate you asking.
Great. Well, thank you so much, Nicole. I think we can move on to our second presentation now. And just as a reminder, we will have 10 minutes at the end of this session for a group chat in case you have questions for Nicole that you didn't get to ask. So our second presentation is from John Sarian and Addie Armstrong from the Blueprint for Health, and Amy Kinner and Alex Ma from OnPoint Health Data. And again, just a reminder that full bios for all of our presenters are on the screen below the video panel.
I'm Addie Armstrong from the Vermont Blueprint for Health, and I'm here with Alex Ma from OnPoint Health Data to talk a little bit today about identifying mental health and substance use disorder treatment needs and challenges within the state of Vermont. So first off, the Blueprint for Health mission is to connect Vermonters with whole person care that is evidence-based, patient-centered, and cost-effective. We are a state-run organization that provides programs that support providers, including multi-payer funding to patient-centered medical homes and community health teams. We provide population data and data analytics for policymakers, and we provide learning labs for providers and community partners. We are not an ACO. We are instead a group of state policymakers, program managers, and operations research analysts who are trying to improve healthcare in the state. The Blueprint has been around since 2013, and in 2016, it's really started demonstrating the results that what we were doing was changing healthcare. It took us 3 years to get going. However, like a lot of things in healthcare, the investment in the Blueprint has really not kept pace with either inflation or with the needs in the areas of mental health and substance use disorder, since those needs are increasing over time. And in 2023, Vermont's legislature authorized about $20 million for a 2-year pilot program to expand some of our work. So we came up with this question, which is, are there any historic differences in healthcare expenditures or utilization for patients who have a mental health or substance use disorder needs? And if there are they associated with a difference in Blueprint-affiliated patient-centered medical homes or non-Blueprint affiliated practices? And that's when we turned to OnPoint and said, help us, and I will turn it over to Alex Ma to give us an overview of the data.
Thanks, Addie. So I'll provide some background on the data set that OnPoint generated to drive this study. So the study is based on claims data from the Vermont APCD. This study used 4 years of multi-payer data running from July 2018 through June 2022. The data set includes medical and pharmacy claims, enrollment data, and capitation payment data. And for this study, we limited to claims paid as primary, members with enrollment during the reporting period, and in-state Vermont residents. For this study, the data was broken out using various stratifications. So we broke out by major payer type, by time period, in this case using Vermont fiscal years 2019 through 2022, with the fiscal year running from July 1st through June 30th. We broke out by 3 age groups, by gender, geography of residence, in this case using Blueprint health service areas, Blueprint primary care practice type attribution, so whether a patient was attributed to a Blueprint primary care practice or not, and by mental health and substance use disorders. So on our data set, we ran a variety of utilization, cost, and HEDIS measures. So the utilization measures included emergency department visits, inpatient stays, outpatient visits, and telehealth visits. And we also ran a version of each of these utilization measures, restricting to a primary diagnosis of mental health or substance use. We ran a total cost per member per year measure, along with a total cost with a mental health or substance use primary diagnosis. And we ran a variety of HEDIS measures with a focus on mental health or substance use. We'll look at some of the findings that from our study. So starting at a high level, approximately 1 out of every 4 Vermonters had a diagnosis for a mental health or substance use condition. So we found that 26% of Vermonters had a diagnosed mental health or substance use condition, with 7.6% having a serious mental health illness and 2.3% having a co-occurring mental health and substance use condition. So for Vermont residents with mental health or substance use conditions, these members accounted for a disproportionate percentage of the total healthcare utilization and allowed cost. So of the 26% of Vermonters with a mental health or substance use condition, these people accounted for 87% of telehealth services in Vermont, 39% of the allowed cost, and 48% of the emergency department visits. Looking at the types of conditions that are most prevalent, anxiety was the most commonly diagnosed mental health or substance use category amongst Vermonters, followed by trauma and stressor-related conditions, and then by depressive disorders. One note here is that patients can be diagnosed with multiple substance use, mental health or substance use categories, and can fall under different categories here. A geographic result amongst the Vermont health service areas, the percentage of Vermonters diagnosed with 1 or more mental health or substance use conditions was highest in Brattleboro, with around 28% of patients having a mental health or substance use diagnosis, and was lowest in Randolph with 23% of patients having a diagnosis. I'll now pass it back to Addie for some more detailed statistical analysis.
So after we got these overview results, we wanted to dive in a little bit more and start thinking about, okay, now, are there any differences? We know there are differences with mental health population versus a non-mental health population, but are there any differences between Blueprint and non-Blueprint populations? And to do that, we used 2 proportion t-tests. And I tested all the significance at the 0.01 level. So you can think of that as a 99% confidence interval if you like confidence intervals better than tests. And this allowed us to make some statements regarding differences in populations, and also allowed us to kind of focus the direction of our pilot efforts and make sure we're headed in the correct direction. So first off, with overall individual trends, one of the first things you need to do when you decide to test populations is make sure you have a control group to test against. And we want to make sure that our non-Blueprint population is significant enough to actually do some testing. That graph on the left-hand side shows the proportion of individuals in a given primary care practice type. So the green line, between 55 and 50% of individuals are Blueprint attributed, meaning they go to a Blueprint practice, and the red line below it, between 35 and 40% of the individuals in Vermont go to a non-Blueprint practice. So we do have a little bit of a control group. You will notice the bottom line is none. They don't have a primary care practitioner that they're attributed to. And this group is prevalent everywhere, but they're not such a large group that we need to spend a lot of time worrying about them. They show up less in all utilization measures because they're a group that simply doesn't go to doctors very often. The graph on the right will show the proportion of individuals in the mental health and substance use category, meaning people with one of those diagnoses, in both of these practices. And what's very interesting about this is the blueprint practices have a higher proportion of their patients in this category. And not only that, it is statistically significant and it is growing over time. So this kind of gap is widening. The blueprint practices are receiving more and more patients in this mental health and substance use category, which directs our efforts towards the right stuff. So what are some of the other findings that we had doing these tests? Among the members with identified mental health and substance use conditions, we know already that they make up only about a quarter of the population, but they're using about 50% of the emergency department visits. The tests showed that a statistically significant difference between Blueprint primary care patients and non-Blueprint primary care patients are using the emergency department. So those who have mental health conditions and go to a Blueprint practice use the ED less than those who don't. And that again kind of says, okay, this is good. We should focus on expanding these programs. In a more general sense, not related to just mental health and substance use patients, but all patients, a higher proportion of Blueprint attributed patients were visiting their primary care practitioner every year. And so that might be good. It may also be one of those things that helps us discover these mental health or substance use disorders as they show up, because they're seeing more frequently. And then finally, another good sign for us, telling us that we should continue to focus on this, was that on average, if you go to a Blueprint primary care practice, you spend about $2,600 less a year in medical and pharmacy claims. And so as we go on, we will be running some more tests. We'll start looking at some of the HEDIS measures, some of the telehealth measures, and other things that are showing up as significant uses. And we hope that this will bring us back next year with some, hey, we learned more things. So thank you so much. If you have questions, we are here and we can answer them.
Great, thank you so much, Addie and Alex. We have about 5 minutes for Q&A before our third presentation. We did get one question in the chat from Sylvia Hobbs. Were you able to distinguish any association between Vermont's 2018 legalization of recreational marijuana use and an uptick in substance use disorder, or any heightened psychiatric disorders like psychosis, depression, anxiety associated with recreational marijuana use?
So our data did not focus specifically on that. And one of the things about it is we looked just pre-COVID and post-COVID. So we haven't gone back that far yet. It's a great question. I love it. I'm now excited about it and want to try it. But it wasn't the focus of this particular project. So great question. I'm going to write that one down.
Great, thank you. I kind of had a similar question for you as Nicole, and this might be a question for you, Alex. You had a slide that showed kind of categories of mental health and substance use disorder. Can you talk about kind of how you develop those categories?
Right. So we use ICD-10 primary diagnosis codes, and we based our value sets off of definitions from SAMHSA. So they have a list of diagnosis codes that provide mental health and substance use categories. So we followed their specifications for those categories.
Okay, and Cindy McElhenney dropped a follow-up question in the chat. When you say you use the SAMHSA categories, are those based on ICD-10 diagnosis codes? And if so, is it just primary or does it consider secondary?
Yep, so those are based on ICD-10 diagnosis codes. We just considered primary diagnosis code for this study. You could consider secondary as well, but we focus on primary here.
And we also removed some of the diagnosis codes related to dementia and old age progressions that are not this kind of primary mental health concern related item.
Great, thank you. One question I had was related to your findings that you were seeing lower ED visits and higher primary care use in Blueprint practices. Was that a statistically significant finding?
Yes. So all of the findings that I listed there were statistically significant at the p equals 0.01 level. So you can think 99% confident that there actually is a difference, and Blueprint utilizers use the ED less, which is great, we think.
And kind of a related question, why do you think you're seeing more mental health substance use disorder prevalence in Blueprint health practices, and why it's growing? Do you think it's like a matter of detection, or is there some kind of capture happening?
So there's a variety of options that could be, and I can't really put my finger on it because I'm not a practitioner. But one of the things that I personally suspect is the Blueprint has really pushed screening and introducing a lot of good screening techniques into their practices. And so when you screen more people and you do it better, you're more likely to find what you're looking for. And so it seems likely that part of this is as a result of our patient-centered medical homes engaging in better screening practices. And I think I mentioned this before, but also engaging with the patients more often. So if they are visiting the doctor annually at a higher rate, then the doctor's more likely to catch it. It's more likely to realize that, oh, something came up in your life in the last year, instead of 5 years later realizes, oh, you're back. When was the last time I talked to you? So I think it's probably a little bit of the additional screenings that are in place.
Great, thank you. And we have a question in the chat from Ying Yang. How do you handle patients with multiple categories of behavioral health diagnoses?
Yeah, great question. So patients can fall under multiple categories. So certain diagnosis codes might fall under multiple of the SAMHSA categories. So those that slide that I showed with the each of the categories broken out, those aren't mutually exclusive. You can have patients that fall under different ones.
Great, thanks, Alex. And then Marian Wrobel had a question. You said that you saw a drop in ED use for Blueprint patients. Was that concentrated in mental health visits or medical visits, or did you get that far?
So we did not break out the individual codes for the ED visits. This was a big data pull from all the claims, so we didn't sample it down to that level. It looks like, given that the mental health population is using an overwhelming number of the ED visits in general, that if they had a drop in ED visits, it's probably a drop in their mental health ED visits. That would be kind of our guess, but we don't have any, I can't say statistically significant, I can't say any truth to that finding. That's just our gut instinct and our suspicion, but it's part of our kind of further next steps that hopefully we'll get to talk to you guys about next year too.
Great, thank you. And then I had one more question for you, Alex, about the Brattleboro facility, and you're seeing higher prevalence in that region. Can you talk more about that? Because we're looking at like a member location, right? Not location of care. So what do you think is happening there? Is it just more people have access in that region because the hospital's nearby?
Yeah, great question. Yeah, so there's an important distinction to make. So the geographic regions there are used there where patient zip code of residence, so not location of service. Yeah, and unfortunately, I don't think I have any insight into why Brattleboro specifically had that higher rate of use.
Okay, thank you. Well, I think those are all of our questions, so I think we can move on to our third presentation. Our third presentation is from Ernie Shippey, who is a clinical data research director for Vizient. And Ernie's full bio is available on the screen below the video portal. So take it away, Ernie.
This presentation is on using longitudinal data to look at opioid use disorder patterns. This graph from the CDC shows the death rate by opioids. As you can see from the early time periods in 2002, very few red, which is more than 20 deaths per 100,000. to 2021, where we see the prevalence of deaths has grown much higher. Using medications to treat addictions has had a rarely checkered past. Even though it's quite effective, 82% less likely to die from drug abuse. We see going all the way back to 1914, there was a wave of arrests and persecutions of doctors for using medications to help wean patients off addictions. We saw it again in 2006 when the opioid crisis first hit the news. We started to see a lot of people that were even receiving MOUD had many of their services discontinued due to the role of law enforcement. The beauty of the longitudinal data is we can look at very specific measures over time, not just for the index encounter. We can actually look at what happened 3 years later, what happened 2 years before. So with this data, we have an index visit. We know that was the first visit. We also have 24 months prior, allows us to ask very specific questions, and 36 months after to actually track the journey of these patients. So the first thing we looked at was what was the journey of the patient prior to that first index visit. So we can see 39% of them were introduced to opioids during an inpatient visit. And these are the various different types of inpatient stays that they had. Then we saw about 60% where it was all done mostly through outpatient. We did see a large amount of pain procedures and also mental health. Of course, sickle cell, the pain involved with that disease as well. So we see these patterns. Now with the outpatient, there is the caveat. Sometimes this treatment might actually happen from an inpatient stay that might have been 3 or 4 or 5 years. We weren't able to determine that, but we could see that they were dealing with quite a bit of pain, also with other substance use disorders as well. Back in 2016, we saw about 1/3 of our hospitals were prescribing MOUD on the initial visit for the patient. And we've seen that that's actually increased quite a bit. Now, based on whether the patient received MOUD, we can look at how many OUD-related ED visits they had. So we see the ones that did receive MOUD, pretty low rate of repeat ED visits, whereas it's much higher for those that did not receive the medication on that initial visit. So as we saw from the previous slide, there's a lot of repeat visits back to the ED as people struggle with their addiction. But what we did notice was on patients that received MOUD versus those that didn't, we saw a much different view of the repeats. So we saw for patients not receiving MOUD, they were 7 times more likely to be a high repeat patient, which would be more than 10 visits in the 36-month period. And then they're 18 times more likely to be a very high repeat patient, which means more than 50 ED visits in that 3-year period. We looked at some age demographics. We do see that while it's the biggest cohort was folks under 50 years old, but we can also see that 22% of the patients were over 60 years old. So it's not just a young youth issue, it's actually impacting those dealing with pain going into their 70s. This table allows us to look at other substance use disorders for these folks during the longitudinal period. So we can see for some of the younger folks, quite a bit higher than as they age. But the big one here is nicotine use. We see for those under 50, 70% are also using nicotine. And when we look at the adjusted odds rates for poisoning and overdoses, we see nicotine with this high odds ratio over 2, even though many might consider it a very benign substance. Now, when we look at poisoning events and overdose events, and we look at nicotine associations, we see, even based on the age groups where there's very high with the younger and tends to go down as the person ages. But we still see for someone in their 70s with a nicotine addiction that their poisoning rate is actually higher than a non-smoker that's under 50. With these poisoning events, we wanted to look at longitudinal deaths. So many times the deaths might happen over the 3-year period. So we looked at the deaths, and we looked at these based on whether they had an overdose or a poisoning event. And we can see quite large associations here where having that poisoning event did lead to eventual death. Now we wanted to look at smoking cessation during this longitudinal period. Is going into quitting programs for nicotine working? And we can see with those poisoning events, those that had gone, this is the gray bar, they were smokers, and then they went through smoking cessation. We see a much lower rate there for these various age groups. This is looking at hospitals. So we're looking at hospitals that have treatment centers. We're looking at how much of them do smoking cessation. We see the 25th percentile, it's only 2.1 per 1,000 nicotine patients, whereas we see the top quartile, 54.6. So a difference of 26 times higher rates. So there's a lot of hospitals that are doing quite a bit of smoking cessation, and then there's quite a bit of folks that aren't doing it at the same rate as those that are very aggressive in this. And we have some of our hospitals like Kansas University, they're very big on every inpatient they look as an opportunity to stop smoking. So I think a lot of it goes to the mindset of the providers. Now that the X waiver requirement is no longer in effect, we wanted to look using our near real-time data for 2023 to see if it's actually impacting it. We are seeing quite a bit of hospitals are starting to prescribe quite more MOUD than they did before. So we're seeing some growth there. We probably still need a little bit more time to actually see if it actually is working. We saw a large segment of our hospitals in 2016 were using methadone only as their MOUD treatment. So we looked through in 2020 to see how many of them had switched to add other drug therapies in MOUD. And then we looked at how were their ED visits got reduced as they added more options into this therapeutic realm. We also saw lower poisoning events and less need for inpatient treatments. So concluding, we found that MOUD was very good in the prevention of poisoning and overdosing, which also leads to less deaths. Strong across all the age groups. We saw nicotine cessation was actually working with lower poisoning events, but still we can see there's a lot of opportunity for hospitals to actually implement more smoking cessation. Elimination of the X waiver seems to have improved the availability of MOUD. And we also see adding other drug therapies besides methadone has really helped to improve quality outcomes as well. That completes our longitudinal journey study. Thank you for your time.
Thank you, Ernie. Yeah, please pop any questions for Ernie in the Q&A tab of the chat. Ernie, I'm sorry if I missed this, but I was wondering what your data source was.
So we have quite a few data sources at Vizient. We receive all the data from Medicare. We also receive all payer data from different Blue Cross Optum plans. But for this one, we did it just for our CDB hospitals, which is our subscription. It's mostly 95% of academic medical centers, as well as over 900 community hospitals.
Okay, so it's a nationwide sampling?
Mm-hmm. Yeah, overall, I would say within all of our different data lakes, we have about 35% of the covered lives within the United States.
Great, thank you. We have a question from Mega Ja in the chat. Other than age, was there any other patient demographic explored?
We did look at all the different demographics. We focused on the age groups mostly because that's where we saw the largest variation in quality outcomes as well as use of MOUD. We did see quite a bit of reluctance to use MOUD in the older populations. But we did look at race, we looked at ethnicity, we did look at social vulnerability. But the age groups seem to be the biggest declination of care practice going on.
Great, thank you. And we have a question from Marcella Guccione in the chat. Do you have data on opioids poisoning rates among the states by 2022 to 2023?
We don't have all of the different states. I know we do have large segments of the different populations. So ours are more what I'd call CBSA markets, where we can actually pin down about 114 of the major cities and community centers in those areas. But we don't have full state data sets, except for just some samples that we purchase for different use.
Okay, and then a question from Lindsay Wilkins. Have you been able to determine why nicotine is so closely associated with poisoning events? And what poisoning events were you looking at?
Yeah, so when this data outcome came out, did quite a bit of research and looked through, and we do member research for our member hospitals. So reached out to some of them to go to it. And they say that the biggest issue is just a lot of it is psychosocial. Also because it actually helps with the dopamine centers. So it extends it. And then just anecdotally, we know that in different groups, like especially for like inpatient treatment, you're typically going to go to outpatient treatment through AA meetings, NA meetings. And there is quite a bit of nicotine and a lot of caffeine and coffee being used at those meetings. So we do see that as one of the big measures, but there was quite a few studies. I could send the references to those, but it's very unique to see this using, especially some of the studies that were done by University of Kansas, where they really looked at this deep dive and really looked at how much it impacts them trying to wean the patients off the treatment. So we saw that with the ones that really did the smoking cessation, that it's really working. So when we looked at poisoning events, we're really looking at overdoses as defined by SAMHSA. So.
Great, thank you. And a question from Marian Wrobel. Can you please explain the X waiver?
Yeah, so it probably started about 20 years ago. So it's a program where they have physicians are required to go through a training program with the federal government to get certified to actually prescribe different opioids for treatments, for MOUD treatments. So they kind of required that for physicians to go through this training. And then eventually it went through disputes. I know Trump tried to get rid of the X waiver when he left, and then Biden blocked it. And then later on, Biden administration 2 years later got rid of it. So now there's no longer that requirement that requires them to go through specialized training, and they can use their own education that they've already received to do that and follow some of the guidelines. So it was a big thing to actually do that, because some hospitals or some mental models where sometimes people look down at physicians that try to use it. We saw that in 2006 when I think it was like almost 14% of people already on MOUD had those services denied due to the DEA, even though it was treated by physicians for years to help them wean off those drugs.
Great, thank you for that context.
Yeah.
I think we can open this up now and have direct questions to our entire panel of presenters. So if you have questions, please pop them into the Q&A tab. While we're waiting to see if folks have questions, I have a question for Nicole and Addie and Alex, and it's okay if you don't know, but your research just got me thinking about like first responders, and some states like Oregon have cahoots, for example, where they are able to address certain behavioral health needs via ambulance, either in the field for low acuity or just bypassing the ED and going right to psychiatric inpatient care. And I just wondered if you guys had looked at that, or if you know if the states you looked at have those kinds of interventions.
So we did not look at any of that information in our it's an all payer claims database, and most payers submit to it. And so in one of the limitations of the study that we're doing actually is the fact that we cannot get at individual field level things that may not escalate to all the way to a health claim. And so we don't have any of the reach to really answer that question, although it is a really good question, and it is definitely something we're thinking about, is how do you reach the data that is not just found in your all payer claims database.
Great, thank you. And then we have a question for Nicole from Hiroko Merservi. What was the rationale behind the exclusion of capitated payments from the analysis? And what % of ED utilization was excluded due to capitated payment?
Considering that we only looked at facility ED visits, obviously we wanted to gather those ED visits that were acute or resulted in an admission. But we didn't want to include those physicians or practitioners that received a monthly capitated payment, essentially. We wanted these to be acute visits, not a network of physicians who already had a cohort of patients, something along those lines. But basically, we wanted to only include those acute visits overall, essentially.
Great, thank you. Okay, I have one more question, which is just a general question. What advice would you give to an analyst who's trying to assess, behavioral health, like how to get started, whether that be specific to emergency department use or opioid use? Just interested in any kind of tips you would have for somebody trying to get started researching this type of work.
So general research tips on this kind of thing for me would be, first off, really start by phrasing your question well, because it's easy to ask something that's way too broad. And so phrasing your question very well and saying, what is the thing that I'm trying to compare? For us, we wanted to get specifically at what did the blueprint do or not do for the patients, for the people? What did affiliation with the blueprint change? And so then narrowing it down into, well, where are some ways we can measure this, and really accepting the fact that your data set is going to be filled with problems, because they all are. And we have a very good one, but it's still filled with problems. So really kind of acknowledging that ahead of time and knowing that you're not going to be able to get a perfect answer, and saying, these are the limitations of my data set, but this is what I can answer. This is the question I tried to answer, and here's how I can get information out of the data set.
Yeah, echoing some of that, understanding the limitations of your data set ahead of time. And then for our case specifically, and I think for people using APCD data, building a person level data set off of what you have provides a really good starting point for performing the analysis.
I think one of the big areas is the reason we went to longitudinal is we have a lot of our member hospitals and internal pharmacy researchers asking us these great research questions. But a lot of times nowadays with the behavioral health, a lot of those issues take years to resolve, if ever, or just to be managed properly. So a lot of times we had to look at it and say, is this something that can be answered through just a simple encounter query? Or do we really need to look longitudinally at the journey of each patient and see what that experience is actually looking like? Because it did reveal a lot of things and assumptions that we didn't even realize, especially around the smoking, looking at other substance use disorders and those dependencies.
Great, thank you. And then we have a question from Norm. Does anyone have thoughts about how SAMHSA could update rules in part 2 to be more helpful to data organizations or users?
That's a great question.
Go ahead.
Yeah, I can't think of any limitations that we came across using the SAMHSA value sets. But yeah, anyone else has thoughts?
I thought their resources were great, and the subject matter experts I spoke to were really excellent in really helping us pinpoint and look at different caveats. So I don't really know how it would be improved. It was extremely a great experience on my end.
Great, thank you. And then a question from Lindsay Wilkins. Have you had difficulty obtaining Medicaid data sets from APCDs or state databases?
So I have not had any trouble with that. Our Medicaid database is, it's uploaded, sent to our all-payer claims regularly, and B, I have access to it outside of that. So I've been very fortunate and not had any difficulty with that. It's just been a matter of getting the right access, and that didn't take very long. So I've been lucky.
Yeah, I've had the same experience. I mean, our vendors are really good at identifying the different managed care programs, the different Medicare changes, and giving us lots of milestones and data uniqueness and nuances. So I've lucked out as well.
Great. And then a question from Marian. With such an important topic to use evidence to find interventions that help patients with behavioral health conditions, Addie mentioned that data sets are filled with problems. What can health data organizations do to reduce those problems so that we can improve data quality and do great work?
So this is a great question too. Part of the intrinsic level of the data that we're reaching is it's very personal, it's very individual. And one of the things that data analysts as a rule try to do is extract these very personal things to a very generalized level. And so the categorization of particular diagnoses or the categorization of what type of visit this is can be really hard. And I think one of the things that health data organizations might be able to work toward is a really solid definition of what we mean when we say you are in this category. What does it mean if you had an ED visit for mental health? Or what does it mean if you are a pediatric practice? We have that debate ongoing in our state sometimes. John is smiling because he heard about it earlier today, I'm sure. But we have this happens on a regular basis is, well, I serve this many pediatric patients, so maybe I'm pediatric. And so really kind of hammering down, this is what the definition means. It doesn't solve the giant problem of how do we answer all these questions and how do we account for all the different facets of the problem, but it really does give us a place to say, okay, when I say this, I mean this, and that is the information I can provide. I can provide you information about people who visited the ED for mental health reasons because I mean that as they had it as a primary or secondary diagnosis code. And it's one of these diagnosis codes. As opposed to, well, did they really? I don't know. We don't measure that because we don't know what it means, or we don't look at secondary, or we do. And so that fine definitions would be my number one, like, everybody get your dictionaries out step.
And then I think there's just, you have to be patient. I mean, we start with sometimes 22 different research questions, and then we're only really able to answer 4 or 5. But at least we know those 4 or 5 that we've done are rock solid. So I think you just have to be patient and just understanding that, you know, you're going to come into hiccups. That's okay. Let's just work on what we can work on.
Great. Well, thank you. And Addie, I definitely feel your pain in terms of categorizing visits and patients. So that's a great point. I think this is a good time to wrap up. I just want to flag that if you're interested in having a more personal discussion on a related topic, look for Health Data Deep Dives on Social Determinants of Health Data Sources, which is tomorrow at 2:20 p.m. In those sessions, attendees can interact live with people in the know. And so we hope to see you there. And I just want to thank all of our presenters and Norm and everybody in the audience for such a wonderful discussion today. Thank you.